Hello, and welcome to Talk Over RA webinar. Thank you for joining us today. My name is Eileen Davidson, also known as Chronic Eileen. I am the host and creator of this webinar. I created this webinar in hopes to provide those living with rheumatoid arthritis a deeper understanding of our disease with useful information that they can apply to their everyday life and leave today feeling inspired to take control of their health again. I know I have struggled with this during the pandemic. I've been living with rheumatoid arthritis since 2015, but did not really start to truly understand my disease until I became a patient partner with Arthritis Research Canada. I have chosen this amazing panel of experts because I've partnered with each of them. Because of arthritis research, I feel more confident living well with rheumatoid arthritis. If you don't know, Arthritis Research Canada is the largest clinical arthritis research center in North America. Arthritis Research Canada team of over 100 are creating a future where people living with arthritis are empowered to triumph over pain and disability. Now, please note this webinar will be 2 hours in length, but it will include movement breaks. Breaks will be from Julia McNally, Cristina Montoya, and Urban Poles. These breaks are also available on recording, so if you feel like you need to get up or visit the washroom, please feel free to. Also, a recording of the webinar along with a blog post of the key points of the discussion will be sent to you. So please relax without having to worry about brain fog, pain, or fatigue getting in the way. We're going to be discussing a number of things today, so we're jam-packed. We're going to be talking about what is remission? What does remission look like? What can prevent somebody from remission? How does sleep, stress, physical activity, mental health, comorbidities, and more impact rheumatoid arthritis? How can tracking your symptoms and physical activity help your RA? How can having a more meaningful conversation with your rheumatologist and other healthcare providers? I'm now going to pass it off to Lene.
Hi, my name is Lene Andersen. Our purpose for this webinar is simple. We want to help you get your voice heard. Many people like you live in silence with their RA symptoms, but as a member of this community, you have the power to create change. We can help you simplify your conversations with your doctor so that you are both on the same page about your treatment and help you better understand your rheumatoid arthritis. One note, please be aware that we can't answer questions about your personal medical issues. Use what you learned today to have better conversations with your medical team. And Cristina is next. Cristina, you're muted.
Okay, again, hello everyone. My name is Cristina Montoya. This event is made possible by Talk Over RA. We are not promoting any specific medication. The event is created by patients for patients, caregivers, researchers, and clinicians, or anyone wanting to know more about rheumatoid arthritis. This discussion focuses on the overall treatment of rheumatoid arthritis and not on any particular drug. This webinar is available thanks to our friends International Foundation for Autoimmune and Autoinflammatory Arthritis.
Remember to download the Talk Over RA discussion guide. It's going to be linked in the chat, I believe. It's the Talk Over RA discussion guide is designed to help you have more meaningful conversations with your doctor. It also includes ideas for how to share your experiences in those conversations. At the end of the webinar, we will discuss what questions you might want to share with your healthcare team. Link to that discussion guide is in the chat. If you have a question for a panelist, please use the Q&A section. We will monitor those two sections. Julia is taking care of the chat, but questions for panelists will only go in the Q&A section. During the webinar, you will hear from a panel of rheumatoid arthritis experts. Advocates who live with rheumatoid arthritis include Eileen Davidson, known online as Chronic Eileen, myself, Lene Andersen, and I'm known as the Seated View. Cristina Montoya is the arthritis dietitian, and Julia McNally, the RA yogi and chat moderator. Cristina?
And our arthritis researchers and clinicians, Dr. Antonio Avina Zubieta, rheumatologist, Dr. Linda Lee, physiotherapist, Dr. Catherine Backman, occupational therapist, and Dr. Susan Bartlett, psychologist. And bonus, one individual attending the webinar will win a gift bag of RA-friendly products and services worth almost $1,000. Winner must attend the live webinar and will be drawn during the Q&A portion of the meeting. So stay tuned. Eileen, unmute, Eileen.
Of course, that will be edited out. I'm going to start off with an icebreaker questions for all of the clinicians on the panel today. I'm really curious to know what got you into rheumatology? Antonio, then Linda, then Catherine, and last but not least, Susan.
Thank you, Eileen. Welcome, everyone. This is wonderful. This is amazing, to be honest. Thank you for the kind invitation, Eileen, and the rest of the patient partners. So actually, as you know, I'm a rheumatologist by training. I actually wanted to become a surgeon. But when I was doing my internship, I got in contact with a patient case that nobody knew what it was. It ended up being lupus at the end of the day, but I was surprised how much ignorance on or not well-known disease was, even among the clinicians who were the experts in the field of internal medicine. So I thought, maybe this is a good field for me, where really is more room to grow. And that's what actually would make me to become not a surgeon, but a rheumatologist. And I think I picked the right one.
Well, thank you. The world needs more rheumatologists.
It did.
Linda?
Thank you, and good to see everyone. I'm just looking at the chat. There are people from Germany and India, so welcome everyone. So my name is Linda Lee. I am a physiotherapist by background, and unlike Antonio, never thought that I want to be a surgeon, but I did remember that wanting to do something that it was really challenging, as a physiotherapist, and did not know a whole lot about arthritis when I graduated from my training, but worked with a few individuals with rheumatoid arthritis, in fact, and learned a ton from the experience. But most importantly, it's around the challenge of solving a problem and the mystery of helping people to manage their day-to-day activities and their treatment. So it was the by chance that I got into rheumatology, but it's the people that keep me staying in the field.
Well, having partnered with you in research and as a clinician, thank you so much for helping people be more active with RA. Catherine, you were an occupational therapist and know so much about managing this difficult disease. Why did you get into rheumatology?
Like Antonio and Linda, somewhat by accident. From my very last, when I was educated as an occupational therapist, we still did an internship after graduation. It's all integrated into the educational programs now. And I wanted to visit friends in Prince Edward Island. So I signed up for places in Atlantic Canada, and I was placed in a rheumatic diseases inpatient unit in Halifax, Nova Scotia. So I went there for extracurricular reasons, but I was placed in this rheumatic diseases unit, and the team that was working in that unit was the best teamwork I'd ever seen in my educational program. And I was offered a job, and so I stayed in Halifax for several years, just as the program transitioned from more inpatient treatment to outpatient treatment. So I just really liked the patient population. I really liked the teams, and having worked with a number of different physicians, I liked rheumatologists better than, and the referral relationship that was developed with rheumatologists, I liked that better than the other ones, other teams that I had seen before. So stayed in rheumatology.
Well, we are happy to have you. Now, Susan, you are a psychologist. What got you into rheumatology? Most people think that arthritis is just joint pain, but if you live with the disease, you know it's much more than that.
So Eileen, I thank you for asking that question amongst our colleagues on the panel. I've known many of them for many years. I had no idea about their background, but I too fell into rheumatology serendipitously. I was down in the United States where I finished my training, and I was working in weight and eating disorders. And of course, we did have a fair number of people who had osteoarthritis come into the program. And my first research study was looking at the impact of weight loss on the symptoms of osteoarthritis. But this was right around the time when biologics began to emerge. And so the director of the rheumatology division at Hopkins approached me and he said, you know, I think we could really use somebody with your insights and experience in quality of life working with us. Would you be willing to work with our inflammatory arthritis program? And I said, sure, I know nothing about it. But I then too found that some of my very best colleagues were working in inflammatory arthritis. And so the move for me into rheumatology was pretty easy to make and pretty quick to make at that point.
That's really incredible because, you know, working with you and having learned so much from you when you started not knowing much about inflammatory arthritis, you really are teaching patients and others about the mental health aspect of this. So thank you for joining rheumatology. We're going to start with our next topic and Lene will announce it.
Yeah, we're going to move the conversation to the big topic of today, remission. And what is this magical word they talk about when it comes to living with rheumatoid arthritis? Remission might look different for different people who have RA, and there may be a variety of reasons why someone struggles to achieve remission. But there are always things that we can do to improve our quality of life with RA, and that's what we're going to cover next. Cristina?
Well, this question is for Antonio, Dr. Antonio. From a rheumatologist perspective, what is remission and what percentage of patients achieve remission?
Thank you. You want me to respond in Spanish or in English?
Well, it's up to you.
Because actually, we have some, they're listening even from Guatemala.
Yeah.
Gabriela,
Both.
so welcome.
Please answer in both.
That's great.
I want to hear that.
No, actually, no, that'll be disrespectful for a lot of people. But anyway, for those who are from abroad, and I actually posted in my Facebook and Instagram that you could attend the meeting and ask questions in Spanish, and we will answer the questions. Anyway, well, clinical remission is very broad, and the concept was actually originally defined for clinical trials, for studies, where people could target and compare different strategies of treatments. But we use it actually now in clinical practice as well, because it's possible to achieve clinical remission. What we call clinical remission is patients who have very little symptoms or no symptoms at all, which includes no joint swing, no joint pain or swelling, no fatigue, and it could be with medications or without medications. And there are different definitions. The American College of Rheumatology, now the EULAR, which is the European Association of Rheumatology, they have joined forces. But for clinical purposes is no symptoms, which will be tender joints or no swelling joints, or could be less than one. That's the actual strict definition. At least one as a maximum tender joint or swelling joint. And you can add markers of inflammation in the lab, from the lab, which is either CRP or ESR, which is a marker that we often use, and no morning stiffness. At the end of the day, it's just no symptoms or very minimal symptoms, and that's possible to achieve these days. But remember, those are used most for clinical trials. Now, with the use of electronic and medical records, we actually can calculate these scores, because it's calculated on scores, but in the computer very quickly on the electronic medical record. We just select how many joints are swollen, how many joints are tender, and automatically imports the values of the lab, and the patient adds the score that they feel that they are from 1 to 10, and the physician also scores from 1 to 10, and then you can get a score. That score, if it's below a certain limit, nowadays is 2.6. You don't need to be worried about it. It's calculated by the clinician, but is a threshold that defines who is actually in remission. And you can add is remission with drugs or without drugs. There are some people who could target discontinuation of medications, and we can talk about that later if you're interested in. But that's actually minimal disease symptom, which is fantastic these days. Many years ago, that was actually rare.
And do you know that you have a percentage of how many patients achieve remission?
Yes, it changed on the sample that you actually read the study. When you select a sample from hospitals, it's different from a sample that's coming from the general population. But overall, the magic number actually with, it varies, but it's got between 20% in tertiary care units with no medications, I mean 20% without drugs, but it could go up to 40 to 60% in the general population with drugs. But let's say for medications, the magic number that you can remember is between 1 to 2 out of 5, 20 to 40% is possible to achieve that without medications. However, when you stop the medications, it's very likely that the great majority will flare again. There was a very famous study called the BEST study, which actually randomized people, meaning some people stop the medication gradually and others actually continue with the medication, and they compare who actually achieved remission or sustained the remission. At 6 months, from those who had achieved remission, which was around 20 to 25% of that sample, actually from those 25%, 75 actually became active again within 6 months, which suggests that most people will still need to stay on medications, probably less. But the good news is, again, the great majority of those who flare, again, 75% got remission again when they restarted the treatment. So going back to your question and for the audience, the magic number is around 1 in 5 could be without medications and still be doing well, which suggests that the great majority will still need medication to maintain the remission that they have.
Wow. Thank you so much, Dr. Antonio. I'll pass this on to Eileen.
Thank you. I learned a lot more about remission, even though I feel like I've had to write about it, speak about it so many times. So thank you. That was really insightful. I'm going to open this up to all the panelists. In your research and as a physician, what does remission or better quality of life with RA look like to you? Not all of you are looking at the blood work. There may be other aspects of what living well or being in remission might look like with RA. I'm going to start with Susan and then go on. Oh, sorry. I'm going to start with Catherine, Linda, Susan, and then Antonio.
That's a great question, Eileen. So I don't use the word remission very much because I consider that related to diagnosis and medical treatment and medication management, but I'm really interested in quality of life in terms of how people are living their lives and doing what they need and want to do. So that's the way I define quality of life. Are you able to do the things you need to do or have to do? Because we all have some obligations. Are you able to do the things you want to do or would like to do? Because we all want to enjoy life. as well. And can you do that with minimal disruption? And none of us do it without disruption. We don't even need to have RA. Things go on in life that disrupt the things we need and want to do. So can we minimize the disruption that comes from rheumatoid arthritis? So we want to have just right challenges, not things that burden us too much. We want to have a little bit of joy. We want to have more good days than bad days. So those are the things that I look at to know that somebody is managing their arthritis to a level that enables them to enjoy their lives.
I completely agree. Linda, will you walk us through what quality of life or remission, whichever one you prefer?
Thank you, Eileen, and I'm going to follow Catherine's lead. I'm going to take a quality of life perspective. So from perspective of a physiotherapist, really better quality of life with rheumatoid arthritis is about being able to do things that are meaningful to the individual. But I will also add that not at just one point in time, but as we progress throughout life. So now we know that with better treatment, earlier diagnosis, people with rheumatoid arthritis are living longer. But people with arthritis also have a higher risk of experiencing frailty because of the effect of the disease on the body. Now, when I talk about frailty, it really refers to people's physical and mental resilience, how fast you can bounce back when you're ill, for example. And it is really linked to people's ability to do things they want to do and their quality of life. So in people with rheumatoid arthritis, their risk of being frail is increased even more as they age, and because of a decrease in the muscle mass primarily. So achieving remission really can help to reduce that effect of frailty as people age, and so that you can continue to do things that you find meaningful and enjoy good quality of life. So that's how I look at it.
I have to say, I just love listening to all of you talk. And next, Susan, can you please tell us, what does quality of life or remission with rheumatoid arthritis look like to you?
So I've been involved in leading focus groups in Canada and the United States, in Australia, in the UK and Germany. And we asked people living with RA what quality of, what remission would represent to them. And they all said the same thing. And that was getting my life back and just feeling normal. And what they meant by feeling normal was, I would think about my RA from time to time. I would take care of myself like I would need to, but it wouldn't be the deciding factor. In other words, if I'm going on vacation, I wouldn't have to think about my RA first and then decide, could I do this vacation? Now RA can just become one of the considerations that I take into account when making decisions. Eileen, I would add too, I'm part of a large group of rheumatologists and in academic and community centers across Canada that look at the first couple of years when people develop RA. It's a cohort known as CATCH, the Canadian Early Arthritis Cohort. And what we found in CATCH is really good news in the last few years, because if we looked about 15 years ago or so, maybe 20% of people would reach remission in the first year of their early arthritis. And now what we're finding very consistently is about 40 to 45% are reaching remission in that first year. So that's really fabulous news, because people are getting off to a very good start very quickly.
That is amazing. And, effective treatment early on is so important with rheumatoid arthritis. Antonio, other than the clinical aspect of blood work and everything, what does quality of life or remission look like to somebody that might be living with the disease every day?
I'll go back to that question. I actually would like to follow on what Susan just said, and this is very important for the audience. The remission is easier when you get it diagnosed earlier and when you actually treat aggressively. And I'm going to give you a number. People who come later in the disease process, late diagnosis, late treatment, the actual rate of remission is below 15%. Compared to when you get the disease early on, it could be up to 40%, as Susan just mentioned. And this is actually a very consistent measure that most people are getting through in the recent years. And because the rate of remission now is higher than it was 30 years ago. I've been in practice for more than 30 years, and I remember when I started rheumatology, a lot of people who were in the waiting area, you could see all the deformities in their hands. We don't see that anymore. I mean, it will be very rare unless you get a patient who just in this country immigrated. But that's an important message. It's easier earlier, and if you treat aggressive earlier. So time is a very important and predictive factor for achieving remission. And it could come and goes. It's not a specific defined state. Changes over time, and that's why you have to have a window remission within 6 months, with remission within 3 months, etc. You set up those goals with your team. And now I forgot what was the question originally. Can you repeat that again?
What does quality of life with RA look like to you?
For me as a clinician is the patient actually is able to be independent, self-sufficient for their own care and for doing the activities that are relevant for them. And that actually is the question that I ask usually to the patient, because it changes by the individual. And that's defined by them, but those are the ones. Self-care and doing things that they enjoy.
That is so important. I'm going to hand it off to Lene to ask the next question.
Next, we want to talk about research, and each of you are involved in arthritis research, which can sometimes seem a little removed from day-to-day living with these conditions. Can you tell us how arthritis research helps people live a better life with arthritis? And this time, let's start with Susan, then go on to Antonio, Linda, and Catherine. Susan?
So one area that my research has moved into more recently is really trying to understand what matters most to patients. And that's part of where the focus groups became very important, to talk with patients and hear what their priorities and their values and their preferences are. And we also did the same thing with rheumatologists. And we find, you know, as you would expect, a lot of things line up. Both rheumatologists and patients want to see pain well controlled, disability minimized. But there are some differences, some important differences, and fatigue is a great example. So fatigue is something that patients will often say is the most disabling symptom that they have to live with. And it's been a little bit of a harder sell to get all rheumatologists kind of on board. They're very focused on controlling the inflammation and feel that when they do that, it will help with the symptoms. But there is a bit of a disconnect, and I suspect we're going to talk about that a little bit more. So I'll leave it at that.
Well, and I think you're right. In my experience, when I talk to people in the community, the infamous question about which one do you dislike more, the pain or the fatigue? And the fatigue is always up there as something that can make it really difficult to manage. Antonio, how does arthritis research help people live better with these conditions?
Well, to finding answers for new questions, that will be the easy one response. But I'll tell you what my research has done, or what I was involved when I was doing our rheumatoid, and I still do a little bit with Dr. LaKyle. So arthritis is more than just the swelling of the joints and the impact on the joints. So if you don't treat arthritis, you develop complications. So I've done a lot of research on cardiovascular complications, which is an important aspect. In the old days, we just focused on getting people mobile and less pain and less swelling. But over the last 3 decades, it has been shown that people with any inflammatory disease have complications like early cardiovascular events, heart attacks, strokes. Now we also know that has also blood clots in the legs and the lungs, and those kill people earlier than, or they die earlier than they supposed to live. And the same happens with infections. When you don't treat the disease, actually there is an increased risk of infections, which you will always worry about because of the medications that we take. But in reality, data has shown that people without treatment that persist with chronic inflammation have an increased risk of developing infections. We also know that, for instance, the use of glucocorticoids have complications. So we measure what are the risk of those complications associated with the use of these particular medications. So I think, as I said before, we have seen that through research, people are not developing the same level of disability that they had 20 or 30 years ago. The survival of the new patients in the last decades compared to the people who do not have arthritis has decreased. Still, there is a difference between the two groups. People with arthritis are still dying prematurely, but they're closing the gap compared to what it was 40 years ago. So all these advancements in quality of life, survival, has been done through research. And this is the reason why we should support research. And I would have to say that engaging patients in research like we do in Arthritis Research Canada through the APAB, or the Advisory Patients Board, is great. So I think this is the best way, or one of the best ways, to actually improve the care and the life of people with arthritis.
Well, and it sounds like this is very obvious that the arthritis research that's going on, the more we support that, the more it helps people who live with this condition live longer and better lives. Linda, you're up next.
Sure, thank you. So I actually have three areas that I find I'm really excited about. First is around the use of consumer technology to help to support self-care. Some of the research that we've been doing around using apps and wearables that people can have access to track their symptoms and physical activities, and to use that to deliver treatment. Some of the earlier work that we've shown is that this kind of strategy can help to reach more people, and also help individuals to be more physically active and feel more confident about managing their health. This sort of leads to the second part of some of the work that I'm doing in implementation work that essentially helping health professionals to do their job better. So how do we tailor exercise and physical activity to meet individuals' needs? And some of these work actually help by the use of technology to collect individual data and to understand what are the patterns and trends of people's symptoms and what they do during the day, so that health professionals can counsel and support individuals to move more, but without flaring up the symptoms. So that's a really exciting area. The last one was touched on by Susan and Antonio, is really around a new field in understanding ways to meaningfully engage patients in research. So it's not just getting people to be research partners or co-researchers, but we need to have better ways to support people, and we need to have a way to measure whether the engagement is meaningful or not to people. So I think that this line of work really helps to transform how we do research together, and that it also helped to move the scientific discovery much closer to people who are affected by the result and be able to benefit from it.
No, I think you touched on something really important in terms of how to use technology to tailor individual treatment, because one size definitely doesn't fit everyone, and what might work yesterday doesn't work today. So that's a very intriguing development. Catherine, you're next.
So in my research career, I've mostly been interested in the impact of arthritis on what people need to do. So we've looked at how they participate in paid and unpaid work. So employment, parenting, volunteer work, and leisure and different social roles or socializing that people do. And then the effect of rehabilitation interventions. So the effect of occupational therapy and physiotherapy on helping people live better with arthritis. So this means a lot of learning occurs in that research environment that we then want to take and share with health professionals and people who are living with arthritis. And like the others have said, that research is very collaborative, and very importantly, patient collaborators shift the research questions into things that are more important to living better with arthritis. Early in my research career, I sat around a table of researchers that was developing a team grant, and we did have patient partners involved. And when we were talking about different ideas or different research questions, I swear I said at least 4 times that the first thing to go is leisure. People stop doing their leisure and recreational activities because of the fatigue and pain and symptoms of arthritis. And then it disrupts their different unpaid roles. And then when it disrupts employment, suddenly people start to listen because they don't want to lose taxpayers. Or they don't want people to need the social safety net that we might have, or things like that. But that never got picked up in terms of collaborative things until a patient collaborator said, you know, when I talk to my friends who have arthritis, leisure is the first thing they let go. And that's how we know that we're not really controlling our arthritis. And then all the other researchers said, we should really ask the patient perspective, like what's the most what's most relevant, or what are the most important questions that we can look at? And that's when we started listening more about not what the symptoms were, but how they actually impacted what people needed and wanted to do. So that's where we start listening a little bit more about the fatigue and the impact of fatigue. And how it's different than being tired, but how it really has an influence on the things that people need and want to do. So I think that research really does inform practice and informs all the self-management, because you only see health professionals for a tiny, tiny proportion of your life. And so you're living with this on your own, or within your own family and community. So we really need to get information that's useful to people living with the disease, and patients teaching patients is a great way to share that information.
Yeah, and I think you make a really good point about how important it is that the research actually reflects what the issues are for those of us who live with it, which is a great reason to our audience to, if you ever have the opportunity to get involved in research and you have the energy, please do. Also want to just a reminder, I'm seeing some questions in the chat. Remember, if you want to ask something for the panelists, it should go in the Q&A. And I think Eileen is next.
Yes, thank you.
May I do a comment on what Catherine just mentioned, since this is quite
Absolutely.
So I think this is very important on the leisure. And in fact, this is one of the aspects I'm just talking about myself when I leave the room for research and go as a clinician. This is one of the things that I often ask patients when they getting better, they actually start regaining that leisure activities that they do, and then realize that this is possible. And that's a very good incentive for them to actually become adherent or follow the agreement that we made with clinicians. So this is a very important marker. Going back again to the question of quality of life, that's actually very important. It's a very good response or marker in general of good response to treatment, and it matters for both the clinician, but mostly for patients and their family.
I totally agree. Now I'm going to ask all the panelists, as your profession, can you please explain how it benefits somebody living with rheumatoid arthritis? So what I'm curious to know is, Antonio, what exactly is the role of the rheumatologist? What is exactly the role of the physiotherapist? What is exactly the role of the occupational therapist? Because that one tends to confuse some people. And then how does mental health support help rheumatoid arthritis?
Well, let's start with the role of the rheumatologist, which is the one I actually play. The role of us is making the diagnosis, implementing a plan in terms of pharmacological and non-pharmacological, and follow up the disease activity of the disease itself. So that's initially the main role that is expected from us. And people play different roles as an advocate for, I think we should do an advocate for the patient, for getting the proper referrals, for doing the coverage of the medications that may or may not be covered by the insurance plans that they have, or requesting a coverage by the government through our taxes. Basically that's the role that we play in this society. And I think is the key one for the disease itself, and being the advocate. And I think this is the part that we not do it consistently. I think I have to acknowledge that rheumatology is the entry door quite often. And if you don't have a good advocate there, the patient may not get the proper referral for mental health, for psychiatry, for psychotherapy, for physical therapy. So, but that's how it is defined, the entry door to get the services and be the advocate. But is disease control our main role?
I learned something new. I never actually clued in that my rheumatologist is an advocate for me too. Thank you. Linda, can you please explain what is the role of a physiotherapist with rheumatoid arthritis?
Yeah, no, thank you. Thank you, Eileen. So as a physiotherapist or physical therapist, depending on which part of the province you are, we call them different ways. The obvious, sort of role would be related to, exercise and physical activity. So that, in general, but also we work as, people who are bringing, helping people to find resources, to engage in meaningful or physical activity that people enjoy, that bringing awareness of the importance of living a healthy 24-hour day, with a good balance of, sitting less, moving more, and sleeping better. And also, the advocacy role, cannot be understated, as what Antonio mentioned. I think there is also a very unique part that physiotherapists, and I'm hoping that my profession will really, jump in with both feet, is around supporting healthy aging in people living with chronic diseases, including rheumatoid arthritis in particular. There's some really nice work done in British Columbia, for example, around falls prevention. And how to support people to, to move more, sit less, and sleep better. So, so that's, sort of the work that a physiotherapist would do. But I'll also add one more thing, is that depending on where you are in Canada, the role of physiotherapists and occupational therapists are not that clearly divided. So, provinces like Ontario has a primary therapist model, for example, where roles can interchange. So I think depending on where you are, you will find, physiotherapists engage in different roles in working with patients.
All right, thank you so much for that. Catherine, now please walk us through what an occupational therapist is, because I don't think everybody knows what you do, but you are magical wizards to living with fatigue.
Yes, we graduated from Hogwarts. So occupational therapists analyze everyday life. And so part of the reason people will say they're not sure what an occupational therapist does is because if they've heard about it or they've talked to somebody who's had it, it's so individualized to the activities or occupations that that person does. And so that's why it's really hard to say we do one thing. So we analyze the fit between what you want to do. So the occupations, they don't have to be paid work, but the things, the activities, the things that you need to do on a day-to-day basis, your abilities to do them, or your capacity to do it. And that's the RA symptoms can get in the way of your personal capacity or ability to do it. And the supports or barriers that are in the environment. So if we look at the fit between what you want to do or the demands of those occupations, what your abilities are are at the present time, and what kind of supports or barriers are in the communities. And so it can be the built environment. So like sometimes you can't grasp a tool in the kitchen, so it's the built environment, but other times it's attitudinal at work. You need a little bit more flexibility in your place of employment in order to get your job done and concurrently manage your arthritis. So the barrier is more of an attitudinal one or educational one with your coworkers or supervisors in the workplace, for example. So the occupational therapist collaborates or works with the person living with arthritis to adjust that fit. So sometimes we adapt to the environment. So we might provide an ergonomic assessment in the home or workplace and shift the supports in the environment. We might work with you to develop your abilities. So maybe you need to better manage fatigue, or maybe a splint will stabilize a wrist joint or a thumb joint, and that'll enable you to do some activities a little bit more effectively. Though we look at the ways that we can support you in doing the things that you need and want to do. And so we need to see and observe and ask about those different activities and where they're done. So we want to make sure that you can work some and play some and laugh some and, you know, enjoy your life. And that's going to be different for each person.
That is so true. I do notice a lot of people are asking if it's going to be recorded. It is. Definitely. If you need to leave, that's fine. I will be putting it up on a blog post so you can read it or you can view it later. Same with the breaks. So we are going to go on to Susan for what can mental health support do for RA. And then we're going to be taking a small break, which does have a video by Cristina Montoya. Susan, take it away.
So I'm going to focus on depression because we know more about depression in RA than we do anxiety in RA, although that's changing, and I'm grateful that it's changing. But, you know, one of the things we've learned about depression is that it is a systemic inflammatory disease. In other words, if you have systemic inflammation and it attacks the joints, maybe it is that we call it RA, and if it attacks the brain, perhaps we call it depression. Nevertheless, we didn't know this because we didn't routinely measure inflammatory markers in people who were depressed. Now that we've started doing it, we see that there's this synergy. And that also explains why we see higher rates of depression and anxiety in people who have rheumatoid arthritis than those in the general population. So about 30 to 40% of people with RA also are clinically depressed. That depression is really important because people who are depressed have worse pain, worse disability. They have more difficulty coping with their disease, and they're much less engaged in doing the things that they want to do that bring meaning to their life. So it can become very much a vicious circle. Depression has a profound impact on quality of life, and it is also treatable. I want to underscore it is treatable. But the depression will change how you think, it changes how you behave. And so we see that people who are depressed also are much more, much less optimistic about being able to get effective treatment for their RA. They're much more likely to not take their medications regularly. It's one of the best indicators of someone who's going to be non-adherent to treatment is whether or not they're depressed. People who are depressed also tend to smoke more, eat more, move less, and all of those things are hugely problematic when you have rheumatoid arthritis. So natural and normal for depression to emerge at some point in a person's journey with rheumatoid arthritis. You know, it's also just tough living with it. It's tough getting access to the care that you need. If your mood is impacted, definitely speak with your rheumatologist, speak with your care team. Let us look a little further and see if some help around depression may be an important way of getting you to a much better quality of life.
Now we are going to jump into the next part of the discussion because we still have lots to answer. Now I've picked these questions based off of my experience attending the last 3 rheumatology conferences over the last 3 years with European, American, and Canadian rheumatology conferences, I've sort of noticed trends to why people with RA are not reaching remission or a better quality of life. There's a number of things I've noticed. That's mental health, stress, lack of physical activity, smoking, alcohol, as well as heart and lung disease, which is common with RA. So I've kind of designed these questions around knowing and understanding more of that. One question that I see so often and has been asked already in the Q&A is, why do we go to the rheumatologist office and we're told our blood work looks great, we should be fine, but we don't feel fine? Why is that? Especially we might not be dealing with fatigue, but we might be dealing with a lot of, or sorry, not a lot of pain, but a lot of fatigue. So I want to know first from Antonio, but I would also like to know the perspective from the others on the panel, because maybe in their knowledge, they have examples to be why somebody may be experiencing pain and fatigue still, even though they're supposed to be really close to remission or better quality of life.
Great question, and actually quite relevant for both the clinician and the patient. So I think it's not everybody correlates well with the marker of inflammation in the lab versus the disease. So early in the diagnosis process and the initial management, you actually can see if this is going to be the case. We call this concordant or discordant. And that applies not just to rheumatoid arthritis. We actually see this more often in lupus, where you have markers of inflammation or active disease and the patient's feeling the opposite. It could be both ways. Your marker of inflammation is very bad, but the patient is actually feeling really well. And that has those caveats as well for both. So I think this is important to establish if this is going to be a concordant case or a discordant case early on, so the patients can help themselves to monitor, because nowadays a lot of patients can get access through the lab results, and then we discuss what will be the marker for you that you look for, and they can actually match this when they get the report through the apps that you have your lab results in your phone. And also, when we don't see this correlation in a patient that was concordant, then there is also this question for us as clinicians. Is this actually residual inflammatory disease going on that we cannot perceive? Remember, we usually do the analysis by joint exam. And we as humans, and that applies to physicians, we're not perfect. We may miss some inflammation. Fortunately, nowadays, there are new tools to assess inflammation that we cannot perceive with hands. That includes MRI, ultrasound, and artificial intelligence, which is coming into place very soon. So those are the questions that we always ask first. Is there anything that I'm missing? And that includes disease activity versus other aspects that influence, like depression, poor quality of sleep, which impacts fatigue and pain. Those are the questions that we always have to ask ourselves. And as we have to have the time to dig in, is there anything happening? We all refer to this imaging if it's needed, etc. So that's quite common and has to be revisited every time. And the goals change with time as well, right? So if you're not achieving your goals, then we have to revisit why they're not happening. And I stop there.
That's definitely true. Leading into the mention of depression, Susan, can you talk to us why a patient might be having a better quality of life, but they're still experiencing symptoms or pain?
So this is often referred to as smoldering disease. And so you do see this disconnect in some people where objectively, when you look at their inflammatory markers and when the rheumatologist does the joint exam, things look like, the disease is under pretty good control, but the person really doesn't feel well and they're not able to get back to their life in the ways that Catherine described a little bit earlier. That disconnect becomes really important. And I think that disconnect is the best red flag that we have, really, that mental health may be in play here, as I talked about a little bit earlier. There was somebody in the chat, for instance, who talked about feeling guilty. I can't do as much as I want to be able to do. And, you know, women fall into this trap all the time. Women with and without RA tell themselves all the things they should be doing. And they often are the person who's juggling many, many different things within the family to try and, you know, get the kids ready for school, make sure there's dinner on the table, make sure that shopping is done in advance, remembering when the laundry has to be done. In psychology, we call this shoulding all over yourself. But part of learning to live with your RA and manage your RA means, you know, getting a hold of these expectations and making sure they're realistic and they're appropriate. And there are days when you just have more energy and you're able to do more. And there are other days when the best thing you can do is listen to your body and lay low. But if you know, objectively, your rheumatologist is reasonably happy with how your joints are looking and your blood work looks, and you're still not feeling very good, it's really important to talk with your doctor about this and to see what other factors may be in play.
Thank you for putting that into words that I feel that didn't really have an answer to why. Now, I guess there's some other culprits that can pop up with making me not feel so great, even though my blood work is coming back fairly decent. I'm curious to know from Catherine and then Linda, from your perspective, what could be causing this?
So I think when you hear that message about the blood work, it's maybe telling the rheumatologist that this medication is doing its job, but life is not just the medication. And a 3-year-old is exhausting. Going to work full-time during a pandemic is mentally exhausting. So these ups and downs and uncertainties. And so, you know, we were planning to do this today, and at the end of the day, I didn't get one thing off my list, and it happened again the next day. And so, as Susan mentioned, we beat ourselves up a little bit. So sometimes it's a crapshoot, sometimes it's a delicate balance. And so we're not feeling well because there might be a little bit of smoldering disease activity that influences our pain and fatigue experience, but it's life that also gets in the way of some of these things. And the uncertainty that we're living with, or the unexpected things that happen, that causes us not to feel well. It feeds into depression. It feeds in to our confidence or lack of confidence. And so it's probably a signal that we need to give ourselves a break and do some of the things that make us feel better. So how is it that we pamper ourselves a little bit, or connect with family or friends, or, you know, so sometimes we need to vent. Sometimes we just need to set things aside and do something that makes us feel better in a more general sense. So it's not always the arthritis. It's a combination of all these factors, or all these things coming to a head.
So true. Linda, now physically, you have a lot of answers why we might not be feeling well.
Yeah, so the blood work tells the story about whether the medication works or not, but especially when someone is coming out from a flare-up, they may not be doing a lot of activities or exercise for a period of time. The muscles may become weak. The surrounding support structure may not be as strong as you would like. So when people re-engage with their usual activity, or even just going out for a walk, that can be quite uncomfortable at the beginning. It takes a while for the muscle to build back. So that could be one of the reasons why, sometimes when you look at the blood work, it looks like the disease is well under control, but when you're doing things, it's still, causing quite a bit of discomfort. The other thing is that Susan mentioned the smoldering disease, and it's true that even, you know, with the condition is, you know, under good control, there may be still some underlying inflammation that's going on within the joint, and that can put the joint at a higher risk potentially to get secondary osteoarthritis, for example. It is a risk for, you know, causing subsequent damage as we, you know, start to get a bit older. And so that could also cause, you know, discomfort as people are, you know, trying to be, you know, doing their activities. And even if the disease is under control, if the joint is, you know, have some damage in the, you know, as time goes, that could be one of the reasons why people still feeling a little bit of discomfort when they're doing things.
Absolutely. You know, it took an ultrasound for me to understand that, because I was told my biologic was working great, but I was still experiencing pain. And that made me understand that I had secondary osteoarthritis. And I also, my diagnosis of fibromyalgia helped me understand that that was also playing an effect. And so does my depression and anxiety. It all plays an effect. It's not just RA on my plate. Now, Susan, you sent me a quick note that you wanted to mention something about medications.
I did, and maybe Antonio will pick up on this as well. You know, the medications that we use for rheumatoid arthritis are life-saving, and they make a world of difference. They also come with a whole host of side effects, and methotrexate is one of the prime offenders. So many people will feel not well immediately after taking the methotrexate, although it's very important for their treatment. But there are many things that can be done. I'm just giving one example. Your non-RA medications can also be really important. Blood pressure medications are notorious for impacting how you feel. So talking with your rheumatologist, talking with your pharmacist, always a review of meds, very, very important, just to make sure there aren't some easy changes that can be made that could actually have you feeling quite differently in a matter of days.
I will pick up on this, and actually I responded this on the chat too. Sometimes when there is this not trust between patient and rheumatologist or any clinician, sometimes this is common belief that less is better, not in rheumatoid arthritis. Sometimes we can see now when patients pick up the prescriptions in the pharmacy. We have seen that there's no refills for the last 180 days. And then you just wonder if this smoldering disease is because patients are, one, not taking the medications as prescribed, or maybe something is happening that has not been discussed. And that's actually something that we have to discuss. There are ways of managing side effects. And remember, as I said before, nowadays it's easier to achieve remission with intensive treatment, but there are many strategies, and you need to discuss this with your physician. Don't be afraid. We actually, there's different patterns of practice, of course, but the old days of paternalistic medicine, where we just scold patients for not taking medications as prescribed, those days are gone in general, I will say. So you have to feel that you trust your physician for adjusting, modifying, and changing the strategy or your treatment. And if you don't have it, fire it. Get a new one. Don't be afraid of that, because this is your life, this is your disease, and you have to trust each other.
May I jump in there, Eileen?
Yes, and then you are also going to be asking the next question as well.
Okay,
so
I just want to jump in as an allied healthcare provider, as a dietitian. When I also get a lot of patients wanting to really treat rheumatoid arthritis or other inflammatory type of diseases with diet, and I automatically, honestly, I just feel like your disease is not well controlled. Please go back to your rheumatologist. And I think this is where you're going to find that that's a responsible answer, instead of you're going to get someone out there saying, oh no, but if you follow this protocol, I assure you, that this is going to get you under control, that is a red flag for you to say, I'm not trusting this. Go back to your rheumatologist. And just like Dr. Antonio, you don't trust that rheumatologist and find a second opinion. But that's really the core treatment. You gotta treat that inflammation and then complement it with everything else, right? So sorry about that. I just feel like it was fitting in there. Okay, so my question. So this is again for Dr. Antonio. A rheumatologist knows that RA can be very serious, especially if left untreated. So for Dr. Antonio, what are common comorbidities with RA that might make it difficult to achieve remission?
The big one is, and we discussed this, is depression. This is a big one because it impacts your life in general, with or without rheumatoid arthritis. Right? We know that the people with rheumatoid arthritis or chronic conditions have more risk of developing depression. So this is a big one that we often miss if we don't pay attention. Other complications that you have is cardiovascular disease, which also limits the type of medications you could have versus those who you could not have. Other is infections, which also prevents you from use some medications, or other complications is osteoarthritis, which could coexist with the disease. That prevents you to do physical activity if you don't recognize it and then you want to help the patient run or do something else better, and so you cannot tailor the physical activity that you're going to do if you miss the diagnosis. And I would say those are the key ones from my perspective. The other one will be probably sleep disorders. It's not a sleep disorder, which is a very common comorbidity associated also with depression. They actually play a cycle and increase pain, etc. So those will be the key ones that we have to look for those and target tailor strategies to target and improve therapy and get the goal.
Thank you, Dr. Antonio. I think Susan has done some research in this topic too.
Actually, we have, and again, it comes from the Canadian Early Arthritis Cohort, or CATCH, and CATCH is conducted at 17 centers across Canada. So we look specifically at factors that would predict not getting into remission. And I was particularly interested in factors that are modifiable, so lifestyle-related factors. We found that women who were obese, so had a BMI greater than 30, and smoked, were statistically unlikely to ever even get out of moderate disease activity. They didn't even reach low disease activity, let alone remission. So if you smoke and you have RA, it's like throwing gasoline on the inflammation. It just really makes it very difficult to treat your disease. And when you add excess weight, it compounds the problem. So we now recognize, fat is not sort of benign tissue that you carry around. Fat is actually very metabolically active, and it excretes a large number of hormones and other chemicals into the body. And those seem to reduce the effectiveness of medications. So those are two things that are really, really important. Managing your weight, staying at a healthy weight. And also, if you smoke, you really need to stop. Get some help with the stopping. It's not easy to stop, but it's one of the most important things you can do for your health and for your RA.
Thank you, Susan. I think Eileen, you're next.
I think I'm next.
Oh,
No, sorry, I had to switch the question, so I'm gonna go first just because we were on the topic of medications.
Okay, no problem.
This question is for Antonio, and I think this one's very, very important. How can a patient tell it is time for medication change, and how do they bring this up to their rheumatologist? You're on mute.
Great question, and very important in the daily life of interaction with clinicians. So the first one is you have to set goals at the beginning of therapy, right? Both of you, the patient and the clinician, should agree. How are we going to measure response? And then the physician will tell you, well, I don't want to see swelling. I don't want to feel tender joints. And then the patient will say, well, I don't want that either, but I also want to have less pain, more mobility, etc. So if you set those goals, then you set a time frame when I'm going to get it. I usually give a target of 3 months. If I start therapy and make a plan with the patient, I go 3 months. If the patient is not there, then I add therapy. If the patient tolerated well, took it as prescribed, then if not getting there, I should escalate treatment. And if, again, you set up again a time frame, where are you going to expect these goals? If you don't get it, then you go to either more therapy or switching completely from traditional disease modifying agents to biologics. And remember, if a biologic doesn't work, you can go again to a different class, there's so many options these days. But I think is defining yourselves together with the clinician, how you're going to measure response and in what time frame. And if you achieve those, then you're okay. If you don't, you should consider complications are impeding the response. And I'm glad that Susan mentioned, for instance, smoking. And I put it in the chat. Smoking is a big problem in people with rheumatoid arthritis and lupus. And in general, all diseases. The efficacy of medications is less if you smoke. Excess weight also decrease response to therapy. So you should target those plan strategies to achieve those, to help you to achieve response. But it has to be time frame and goals that you define in advance. That will be the best indication to decide if you need to switch treatment or escalate.
Thank you for that. Who was going to answer that one next? Sorry, we changed things a little bit around just for the flow. Oh, Lene, it's yours.
Alrighty, so we've heard a little bit about lifestyle habits and events, and we're going to dive into that some more now. Because what we do in our lives day to day matters, from sleep, physical activity, stress management, all of it has an effect on our RA. And although medications are important, we need more tools for day-to-day management of this condition. This question is for all the clinical panelists. What lifestyle habits or events might prevent someone from achieving remission or lowering disease activity? And we have touched on it, but please feel free to go into more depth or talk about additional things. This time, let's start with Susan, and then Catherine, Linda, and Antonio. Susan?
So I think I've really emphasized the things that, you can do that. Well, stopping smoking has really, the benefits are seen very, very quickly. Losing weight takes longer, but even small amounts of weight make a big difference. So people losing, in our studies, people losing as little as 10 pounds noticed a measurable improvement in their pain and in their physical function. And 10 pounds is something that's reasonable to target for 4 to 6 weeks or so. So, once you start, as Cristina, I'm sure will comment, once you start eating better, people feel better. And those results are really important. But I'm going to lend my time to Linda, because physical activity is another place that's critically important. So Linda, I'll let you pick up from there.
All right, let's take a detour around Catherine first.
Okay, thanks, Lena. So routines are so important, and oh my gosh, we've just lived through a major stressful life event in a pandemic that took away all of our routines, and we had to reestablish and develop new ones. And for some of us, it really showed us the power of regular physical activity and regular social connections and regular opportunities to laugh and have fun, and having a reason to get up and leave the house in order to go to work or do an activity or something. So both losing and adding activities can have an effect. The loss of routines and habits can start a downward spiral, and we want to try and guard against that. And we want to bit by bit add to the routines and habits that we know support living well with arthritis. And so I know Linda will talk about moving, but it's not just moving, although that's critically important, and some of the most powerful research comes out of regular physical activity. But when you study what keeps people engaged in physical activity or why they do it, it's often the social aspect. So we support physical activity by doing it in a way that makes people happy. And that's often connecting with other people or some groups, support from friends and family or groups of like-minded individuals. So I think it's you mentioned what you do every day matters, and there's actually an occupational therapy public health research group that's their slogan, what you do every day matters. It's I'm going to put the website into the chat so people can see it, but they talk their project is called Do Live Well, and you need to think of all the characteristics and aspects of the different things that you do, and pull together a combination of things that support your day-to-day routines so that supports your health and enables you to do the things that you want to do.
All right, thank you so much. And I think you make a very good point, like whatever gets you moving. And that is often the social aspect. I know when I look at Cristina's Instagram and her Zumba classes, that even just looking at it makes me happy. Linda, what are your thoughts on these kind of lifestyle habits or events that might help or hinder quality?
Thank you. So, great things have been said already. I guess the only thing that I have to add is that, any movement is good. Social, not social, anything that we need to do, the whole day matter. Move more is better. And if you look at the research around arthritis, that, what are we talking about in terms of like how much do you have to move around and walk in order to keep your physical ability? Work around osteoarthritis in particular, so primarily older adults, we're looking at about 5,000 to 6,000 steps. So think about 5,000 to 6,000 steps is actually not that much for a whole day long. That if you get up and do your household chores, like you don't even have to go to the gym or make an effort to go for a long walk or so on. 5,000 to 6,000 steps is what keeps people sort of physical function and mobile. And so having that habit and build it in the everyday life is important. And one more thing that I think is important for people to know is that even the light amount of physical activity, so we're not talking about going to the gym, just slow walking, standing, doing your chores, not a fast walking type of activities. Even light activities has an inflammatory property, small amount of inflammatory property, which means that it helps your medication to work better in managing your arthritis. So there's just so many good reasons to be able to stay active.
Yeah, I think you're right. It's important to remember that if you look at physical activity and you think, I can't do this, do what you can. It all counts. And I think last on this topic is Antonio.
Well, all the experts on non-medication are already spoken, so I have nothing else to add except that it has to be multidisciplinary. You have to do a lot of things, right? It's not one single thing. You have to think, improve your sleep, etc. So that's one thing. But also sometimes it's okay to not be okay. And that applies in life, right? So don't beat yourself because you have a terrible week, but it's okay. As long as it's not chronic, and there will be days that you don't feel and then you get too much anxiety because of that. No, sometimes it's okay not to be okay as long as this is not persistent. But it's multi-approach that works better.
Yeah, I think you touched on something really important there, like the fact that we all have bad days for whatever reason, and there are days where simply getting out of bed or making yourself a sandwich or a cup of tea, that counts. But also, and we're going to talk a little bit about tracking later, but keep an eye on your symptoms to know when they've been going on for long enough that you should reach your doctor. And I think one of the things that's reflected in this panel is that this is not just about your rheumatologist, it's about asking for referrals to physiotherapy, occupational therapy, mental health therapy. There are a lot of people out there who can help you. And being aware of that and then talking to your doctor about that. I think next up is Eileen.
Yes, sorry for making a few last minute changes there. Now, this question is specifically designed for Linda and then Antonio. Linda, I partnered with you in your research, especially when it came to physical activity and tracking my symptoms. Can you tell us how this helps patients and also helps the rheumatologist have a better conversation and like understand what's going on with each other? And then Antonio, I'd love for you to say, does it help you at all when a patient tracks their health?
Yeah, Eileen, thanks for asking the question. And, you know, I have the privilege to work with yourself and a number of people with rheumatoid arthritis and health professionals to develop this program to help people to track symptoms, disease activity, and, you know, sort of what they do during the day, including their sleep. Really, the whole idea is for them to be able to have this information and be able to share with health professionals in a seamless way so that they can do the counseling on Zoom or on telephone. And we tested that in a 6-month period. So in the work that we've been doing, we look at how the program works, and we found that, you know, like people with arthritis really value the ability to be able to see patterns of the symptoms, and so understanding between sort of how they feel and what they did over time. The program we developed is allowing people to track their symptoms as well as their physical activity and put them side by side so they can see that over time. And with that information, people do feel that they are more equipped in terms of self-care. And we talk to people, we interview them about, you know, sort of what are, like, why do they think that it worked for them? And one of the things that they told us was that when they start to gain a better understanding of their health over time, that they felt that they were able to make better, have better information to share with their doctors, their healthcare providers, their exercise professionals, so that they can work with them together to, you know, sort of discover the best treatment options together. So it's really, it's powerful to, you know, have this control in their own hands and be able to work with their health professionals together.
I know that I benefited so much from tracking my health and the program that you created. Would you please pop it into the chat so everybody knows about it? I will also include it in the blog post, so if they're interested, I highly suggest it. Antonio, how does tracking health and symptoms help you and your patients have a better conversation?
Well, to start with, is makes the time more efficient, right? There's a limited amount of time you're going to spend in the clinic. So if you have discussed and you track the things that are relevant, again, you have to have an agreement and understanding why those are relevant. It makes your 20-minute or 30-minute more efficient. So, and then setups the next targets. Are we doing okay? We're not doing okay. We need to change treatment. So definitely it does help. And then you spend the last 10 minutes talking about the dog, the next trip, and it's more collegial, fun discussion rather than spending all over the map, sharing symptoms that are maybe or may not be relevant, that you may think are relevant or not relevant for the disease activity, etc. So that, I think that's critical, and has been tremendous amount of research by Linda and by others in Arthritis Research Canada, like Paul Fortin has done very similar measures in lupus. And so there has been tremendous amount of research that shows that it definitely improves the quality of care and the outcomes of people with inflammatory diseases. So I think it definitely helps me as a clinician to see if what we're doing together is better or if we need to change strategy.
I agree. That's really insightful information. Lena, it's your turn to take it on to the next question.
Thank you very much. So now, hang on, I'm going to find the next question because there was changes, so I'm confused. All right, we are going to open the discussion here to the RA advocates on the panel. What are some of the lifestyle changes you have made to get a better quality of life with RA? I'll go first and then pass it off to Cristina and then Eileen. And I swear I did I did notes. So I've done a number of things. One of them is that my diet I've shifted to a more plant-based diet. Now I am one of those people for whom diet doesn't do anything, either good or bad, but so it doesn't affect my RA, but it does affect my general health. I feel better when I eat more plant-based. I also take a nap every day. I treat it as sacred, as non-negotiable. And that's taught me a really valuable lesson about setting boundaries and how important it is, and protecting those boundaries, even when it's inconvenient to others, that I come first in this respect, and my ability to keep going comes first. I have a therapist, which has made a huge difference. As we all know, the last couple of years have been really hard, and as someone who's immunosuppressed, it's been a ride, let's just say, not a good one. So having a therapist to help me work out a number of things and also support my journey into setting more boundaries and protecting myself, and my ability to keep going was really important. And lastly, I'd say that prioritizing fun, in the sense that I think it was Catherine that said that when you don't feel good, the first thing that goes is leisure, because you have to keep working so you can pay the rent and all of that. And I think making sure that you find ways to enjoy your life, because that is what we're here for. I think, like, sure, paying the rent too, but that's not the purpose of life. So I think finding something that makes me happy, and makes me laugh, and makes me connect to the beauty and joy of living was incredibly important. So that's me, Cristina.
Well, thank you, Lena. Well, as a dietitian, nutrition has been always play an important part of my life. And now because of arthritis, precisely, it's because of my strong family history of diabetes and cardiovascular diseases. So then after learning from rheumatoid arthritis, kind of the risk of cardiovascular diseases, I find that, hey, I'm in my 40s and I don't have any of those diseases. So it works. So that's important for me, more also like a plant forward diet. After my mental health awakening, I find at least dedicating 30 minutes to like a nature therapy, and it's something simple, just go and walk out of my deck. I'm surrounded by pine trees and birds, And I think just having that moment to myself, not thinking about anything else, has been very therapeutic. And another thing is finding joy in exercising. And I love Zumba, as like everyone, so much so that I'm going to get a certificate to be a Zumba instructor. I am. I registered. So it's really finding those like fun things in life that, and that purpose. And my main purpose right now is that I want to be there for my son. He's 3.5-year-old, and I want to be there for his high school graduation and college graduation, and that's my intention. Thanks. And now, Eileen.
I muted myself. I actually did the good thing, and then I messed up the flow. I think you touched on something really important. The idea of finding out what your motivation, your why is. Like, why are you doing these things other than feel better? Which sometimes we're not so good at focusing on us, but focusing more on other people's needs, but finding that motivation to why am I doing this? And for you, it's about being there to see your son grow up. And I think that's really important. Eileen, you're up next.
Well, I definitely can reflect everything that has been mentioned, but for talking about one that hasn't been mentioned, that I've started doing since my RA diagnosis, and that is becoming a volunteer and participating in research. That has had such tremendous value on my life. Because I do that, I know all of you on the panel. I am able to give back to my community. I'm able to drive change forward, and, you know, help people understand what they're going through. And I think that was the biggest lifestyle change, was me becoming a patient advocate, plus all of the, you know, being more active, eating healthier. And then I guess I'm also going to mention, I was diagnosed originally at 17 with clinical depression. And at that time, I was told, you know, lose 10 pounds and you'll feel better. So I walked away with a lot of guilt for a long, long time about how I felt. And so a huge lifestyle change or mental health change was addressing that it wasn't my fault, going to therapy, making changes, and then doing productive things in my life to make change in myself. And yeah, so that would be my answer. Cristina, we have one more question, and then we're going to open the QA and announce the winner. You're on mute.
You're muted. You're muted.
Yes, ladies. Yes, we're almost there. Okay, so all patient panelists too, if you had one message for those here today, what would it be? And let's start with Lene.
Only one? I think the biggest thing is to remember that this is your life. And you're in charge of what happens. You're the person in control. Find a medical team who works with you as a team member, who recognizes that your goals and how you're feeling is what has to drive the bus, so to speak. And I think finding ways to understand I'm piggybacking here, but it's all connected, that when you understand your illness and some of the things that can drive symptom and flares, I think you get more of a sense of control. Like, for me, I know that my nap, for instance, is an important part of my ability to keep going. So I control that. And I think with a condition that can often seem like it takes control away from you, finding ways to remember that it's still your life is the kind of the driving factor for everything else that follows.
Thanks, Lene. And I'll chip in next. I'll leave Eileen last. I said to you, you are enough. You know, rheumatoid arthritis or not, you are enough. And rheumatoid arthritis doesn't define you, and you still can find your zone of genius. What makes you unique? And share it with the world. You don't want to share about your arthritis and all that, deal with yourself, that's fine. but also find that genius and share it with everyone. And one thing is practice self-compassion. Talk to yourself like you will talk to someone you love and is in need. We tend to really be so hard on ourselves. Will you talk to someone you love and they come and ask you for help and say, but are you stupid all this? No, you say like, but what happened? So remember to talk to yourself like with love and self-compassion. That's me. And Eileen.
Get involved. Participate in research, volunteer with organizations, meet other people, write about it, blog about it, TikTok about it, whatever. Just get involved, be loud. I think it has been the most empowering thing I have ever done. And I want everybody living with RA to feel empowered like that as well. And yeah, Cristina, we are going to take it now to the Q&A portion. We may only have time for a few, as I see there's a lot. Cristina, have you managed to find some that would be great questions to answer, or do you need a little bit of guidance with that?
No, I do have it, but first of all, thank you so much for such a great discussion from all the panelists, and also from the discussion of the participants in the chat has been amazing. Let me see, just one thing that is I guess an easy one I can ask Dr. Antonio is, are there any ways to prevent joint deformity?
Yes. Control the disease and use physiotherapy and occupational therapists. So remember, earlier is very important, and aggressive treatment earlier is important. But physiotherapy does an amazing work, and there are some resources there for hand physiotherapy in special centers, and I think this is the ultimate goal of treatment is to prevent deformity and improve quality of life. The sooner, the better, and the more aggressive you are at the beginning, the better. And use physiotherapy and occupational therapists to prevent that. They're very useful, amazing.
So for the Linda and Catherine, so can you give us one tip that we can use to maybe prevent those joint deformities? Linda?
I was hoping Catherine will go first. Well, one thing that's really is to keep, your muscle, the structure, that support the joint as strong as possible, and as tip-top shape as possible. That helps, for you when you're, doing things that you enjoy, without the risk of, hurting the joint. And the other thing, around joint deformity, I think, is contributing to the risk of falling, in arthritis. And I think that's something that cannot be understated. And, so there are a number of things that can be done in terms of balance, in terms of activities to prevent falls. But I'll stop there.
Thank you.
So it's really individualized, but the way you do what you do is important in reducing or minimizing the chance of deformity. So if I was going to pick one and choose the hands to really avoid a tight, static, persistent grip, so that you maybe need to choose tools that have a larger, softer handle or grip on them. But I would advise you, if you can find an occupational therapist or a physiotherapist to work with you and figure out what you do and what's the best position to put your joints in when you're doing those things, then that in combination with the strengthening exercises that Linda talked about are probably among the most important things to do.
Okay, thank you. Thank you, Catherine. This question is for Susan. Is there any specific therapy or mental health therapy aimed for chronically ill patients like us?
So there's been a lot of work that's been done. Some of the best work actually has come out of BC. and a psychologist named Dan Belofsky, who's developed a series of workbooks a number of years ago that have been tested and proven to be very effective, very helpful, useful. I use them with the people that I work with. They're freely available. If you Google positive coping for health conditions, it will get you to a number of websites where you can download Dan's workbook. Now, what the workbook does is it leverages all the principles that are tried and true foundations of cognitive behavioral therapy. So, you know, learning to understand what you're saying to yourself is really important so that you speak to yourself in a positive and supportive manner, as Cristina mentioned earlier. And also just how do you change behavior? It turns out it's incredibly hard to change our behaviors. It's like we're hardwired to get stuck in our habits. So the best of what's known about how to do that effectively is in Dan's workbook. And it's just a very complete, comprehensive, and easy to read guide to being able to be the best self-manager you can be.
Could you just repeat his full name again?
Dan Belofsky is his name. I'll put it in the chat.
Thank you.
Maybe this is for Dr. Antonio, and even though we're not really going to talk or address any specific medications, but there's a couple of questions about cannabis and arthritis. If there's something you could offer related to that, it seems to be avoided by physicians. Is this due to a shortage of information or statistics?
This actually, I do use cannabis, not myself, for patients. So I refer to clinic. There are 2 clinics, at least in BC, who the initial assessment is done by a GP. We'll go through all the medications you take, look for interactions. There is few research, but it's developed now currently more research happening, and that's important. Before, there was no good data to support the use of cannabis. Now there is emerging data that shows that can be useful for pain management and sleep. However, there has to be, remember that the component that works for these aspects is not the THC, is the CBD component, which is not the one that makes you happy and high. So that's why it's important to get a prescription from those places that have been assessed by clinics, because they can control the amount more or less homogeneously of CBD versus THC. So, and it's useful. However, this is not the magic bullet. And it has to be understand this, because if you're hoping to get this and forget about the other therapies, and that's not going to happen, and you're going to miss opportunities. Okay, so as long as you understand this, and we have to keep waiting for data to show. We often accept therapies that are supposed to be magical, and we don't submit those to the critical scientific rigor that we do for other therapies. And you have to be very careful when you choose to take an alternative. Make sure that it's actually scientific evidence to show that. So just remember, this is not the magic bullet. It is just one more possible therapy. And there is no, at least in these days, I think that we're just waiting for data to show that it's going to be useful. But it's not still the magic bullet. And we'll have to see.
Yeah, thank you, Dr. Antonio. And I'm aware that in Toronto, there is a study going on where they're studying the effect of cannabis in sleep, pain, and anxiety. So they're trying to bring the medical, real evidence of using medical cannabis. I have one question. This is for all, and I found it very important, is that what tactics or strategies have you all come across to assist in the barriers that affect Black and other racialized folks with RA or chronic pain? So let's start with Sue. Let's start with Susan.
I think I would say first, thanks for bringing this up. And second is we just don't know. We don't have enough information. For 20 years, I worked at Johns Hopkins, and that's in inner city Baltimore. And so we did have a very large African-American contingency who would come in, and the problems are different. We understand in lupus that the disease is very different, but I don't think we know enough about RA to really understand what the differences are. They are important. We learn from patients all of the time. So I would say keep asking these questions and keep pushing us to come up with the answers, so that we can make sure that the treatments that we develop can be helpful to the largest number of people. You know, if you know one person with RA, you know one person with RA. And factors are very different, but we need to understand many of the social and other factors that truly impact the ways disease presents, the way it's treated, and the way we improve outcomes in everybody.
Thank you, Dr. Susan. Anyone wants to maybe have some comments?
I do. Response also to treatments is different and has been actually underrepresentation of these groups in clinical trials. So now the FDA or the lupus community, for instance, is demanding to at least have a small percentage or good percentage of people in clinical trials for Blacks, for Hispanics, and for indigenous communities. So this is a big advancement, at least in lupus. I don't see that requirement happening in other diseases, but it's a good thing to see, because they're genetically different, and that depends not just on the risk and the manifestation, but also in response to therapies. So this needs to be discussed openly and make sure that these communities are represented there by addressing the barriers that they have to be included in this research and therapies as well.
Oh, this is wonderful. I don't know if Linda or Catherine have any comments, and we can close our Q&A session to announce the winner of the wonderful gift.
I'll just add that I think that's why it is so important for individuals like yourself, Cristina, and Eileen, and everyone to engage in the research process, because, you know, sometimes when we're doing research, you know, people may just, you know, go and recruit individuals who are easy to recruit. And some of those really important questions don't get answered when, you know, when they're not at the table to help to drive the research agenda and make sure that, you know, people are represented and properly, good questions are being asked in research. So thanks to all of you.
Thank you.
So I'll just add my thanks, and I've been following the chat box here and noticing how many people are saying that this has been valuable to them because they know they're not alone. And so I do really want to reiterate that you are not alone. And also some of the challenges people were pointing out about how hard it is to find a rheumatologist or health professionals. And we acknowledge all of that as well. There's lots of difficulties, but be persistent and persevere. There is a way to live with rheumatoid arthritis that is just as satisfying and enjoyable and productive as you imagined your life to be. It just might be a little bit different than how you first imagined it. So that this type of event that Eileen has coordinated and organized is another way of supporting your journey of living well with arthritis in light of the challenges in the healthcare system where you're trying to access some of the professional resources. So hang in there. There's always light at the end of the tunnel.
Wow, thank you so much. This is wonderful. Now I'm going to pass it all to our lady here, it's Eileen, to announce the winner of the swag bag.
It's actually Lena gets to announce the winner. I gave the fun to her.
Oh, Lena. Okay, go ahead, Lena.
I also want to, just before I do that, acknowledge all Eileen's hard work and everybody who participated and has supported this webinar. It's been truly a privilege and incredibly educational to participate. And now, somebody do a drum roll. We are talking about the giveaway that we've been mentioning all over the place. Let's share details first. We have fabulous Nordic walking poles donated by Urban Poles. Room to Thrive, the program run by Cheryl Crow. Stickers by RA Life Hacks, signed and personalized copies of my books. Shirts by Chronic Eileen and Michael Kaluva. And Eat Love, the program that Cristina Montoya runs, and a fabulous wellness basket. So the drum roll is happening, and our winner is Marla Nolan. I don't know where Marla is from, but Marla Nolan, keep an eye on your email for a message from Eileen that shares information about when you'll be getting your stuff and how we send it to you. Thank you so much.
Well, I'm sad this is over, but my anxiety and my fatigue and lack of sleep is very happy it is. Tomorrow I fly to Philadelphia for a patient advocate conference, but thank you so much for putting some more pep in my step after, especially the pandemic. It's been difficult. Thank you all for attending and helping with your incredible sources of knowledge and involving patients in your work. I love this collaboration between us patient advocates and these researchers. I think this really has been an informative chat because I'm an arthritis writer and I learned so much today just from this conversation. I really cannot thank you all enough. And like we've said before, this will be recorded. If you signed up for the webinar, it will be sent to you. I will be creating a blog post and everything. Do give me a little bit of extra time because I am off to a conference tomorrow. So give me about a week or so. My goal is World Arthritis Day to have it released. So thank you all.